Thank you, everybody. We'll just take a quick inventory of the resources that are available to us. I am Dr. Rohit Saxena. I have with me Dr. Rashman Gandhi, who's the chairperson, Dr. Jayanta Kumar Das, who's our convener. We are waiting for Dr. Anita and Dr. Nibha Anand. If they are here, we'll have them join us on the dais. The first speaker would be Dr. Karthik. Is he here? Great. So just get ready in the meantime while we'll look at the inventory of the other speakers. Dr. Isha Chaturvedi. So we do not have Dr. Isha Chaturvedi at present. Dr. Amrutha. Yes, you are there. Great. Dr. Jubin is here, who'll be speaking in place of Dr. Jolly Rodgi. Dr. Mahfouz Alam is not here at the moment, so we'll just put a dot. If anybody sees somebody of them come in, we'll just mark them. Dr. Prasanna is here. He cannot be missed in this wonderful bright coat. Dr. Elma Varghese. Okay, Dr. Elma is here. Dr. Nishi Prasad. Again, another person we'll hope to get while we wait. And Dr. Rana Jamil. Okay, great. So we have a majority at least who are present. So I'll request our chairperson to start the proceedings.
Good afternoon and welcome to this compelling cases in neuro-ophthalmology. We have a good mix of cases, so would request all the speakers to stick to the time so that we can generate good discussion. Can we have Dr. Karthik to start? It's a 4-minute per case, so try to stick to that so that we can have good discussion on it. Karthik? Hello, Dr. Karthik. Okay, please start.
Timer set for 4.
4 minutes.
And after that, just set for 2 or let it run so that we'll stop at 6 and then maybe we'll have a collective discussion if there's time in the end. So 2 minutes or so, 2 or 3 minutes for discussion.
Good morning, respected honorary delegates. Thank you for giving me this opportunity. I am Dr. Sai Karthik from Sarojini Devi Eye Hospital. I'll be presenting a case of sarcoid hypophysitis of pituitary gland, manifesting as partial Turner palsy and game-changer role of contrast enhancement neuroimaging. A 53-year-old male patient presented to OPD with complaints of mild drooping of right upper lid, double vision and severe headache since 15 days. General examination is within normal limits. Systemic examination and vitals are within normal limits. So, on ocular examination, significant is right eye, there is 2 mm of ptosis in the right eye, lids, and anter-segment examination, fundus are within normal limits in both the eyes. And face is turned towards left, facial symmetry is maintained, ocular symmetry is lost because of mild ptosis of the right eye along with small angle exotropia. At initial presentation, extraocular movements right eye, there is adduction limitation which is -2, all the other movements are normal, and 2 mm ptosis is present in the right eye. So we have advised MRI scan of brain with contrast, but the patient refused and he consulted a neurophysician. On neurophysician advice, patient underwent MRI scan plain. This is on 26th February. On plain MRI scan, it was reported as it was a pituitary macroadenoma, which is measuring 8.7 into 17 into 12 mm. So this is the images. So patient was referred to neurosurgeon based on the MRI scan plane. Neurosurgeon made all the arrangements for the craniotomy and surgical decompression of the tumor. But before shifting him to the theatre, he ordered a repeat MRI scan of brain with contrast. So this was on 1st March. On MRI brain with contrast, it was reported that it was not a tumor, but it is an inflammatory pathology. There is an enlarged pituitary gland, anterior and posterior, thickened pituitary stalk with heterogeneous post-contrast enhancement during compression of optic chiasma. This was reported. So the patient was thoroughly investigated to find out the source of inflammation. Lumbar puncture and CSF analysis was done, which have shown positive for inflammatory pathology. Serum ALP was increased, CSF proteins were raised, acid fast bacillus stain was negative, whole body scan was done, was negative for tuberculosis. Serum ACE levels were within normal limits, TSH, LH, cortisol and testosterone were reduced. Other routine blood investigations are within normal limits. You can see these are the reports. So based on these clinical and radiological serological investigations, the diagnosis of sarcoid pituitary hypophysitis was made and patient landed in hypopituitarism. So we again refer to the neuro physician. High doses of steroids were started by the neurophysician along with pantoprazole. Patient recovered from the partial turn of palsy and got relief from headache, double vision and CHP and fatigability. Neurophysician has repeated the MRI brain with contrast at the 1 month of course of treatment. So this was on 5th 4 April. So MRI brain with contrast showed a significant resolution of inflammation. These are the extraocular movements after the treatment. They are almost full and free. So, concluding this case, sarcoid hypophysitis is one of the rare differential diagnoses for pituitary adenoma. It involves pituitary stalk and pituitary gland, which closely mimics the pituitary adenoma. It is a inflammatory pathology is only when enhanced with contrast MRI imaging. This case exemplifies how important the contrast management is and guides the appropriate line of treatment, avoiding the unnecessary surgical interventions. Thank you.
Thank you, Dr. Karthik. A very, very nice case. I think there are two take-home messages there. That when you request for neuroimaging, you need to know which area you are interested in, because that's the area which radiologist will concentrate on. So that's where we have the focus on clinical examinations. You do clinical, otherwise the argument can be every patient would require neuroimaging. Why do you have to do all this clinical examination? Because so that you can tell radiologist which area you are interested in, and then once you request a neuroimaging, you need to make sure that you ask for the right neuroimaging. So here, I think because the contrast was not given initially, the first MRI.
We have advised contrast,
But they didn't give, yeah. So I mean, because it was not done, that's why the inflammatory pathology was missed out. Just imagine if it was not repeated.
Yeah, exactly. Appropriate investigations are important. As you said, contrast is essential. There are very, very few indications for an MRI brain where I would, be willing to get away without contrast, except maybe acute trauma setting where I may just not. But otherwise, exactly, it's very, very important to note that, and of course, check for differentials. I mean, I'm not sure, we couldn't see the imaging in detail, but when in doubt, always consult with a radiologist directly as to what is the potential differentials and what is the appearance of the lesion before you take a decision on the likelihood of the diagnosis, right? So thank you very much. It just signifies the importance of a radiologist in a clinical practice of neuro-ophthalmology. So keep a radiologist as a good friend and make sure that you interact for every case with the radiologist. That is a key factor.
Just I want to know, it's a very good case, definitely to you and my other panelists. So in such cases, all radiologists may not be possible to say is it inflammatory, non-inflammatory. Is there any other clue as a physician to look for if the neurologist fail? Because that if we refer the case to the neurosurgeon or the even ENT surgeons now they are doing to endoscopically, sometimes there is a tendency they may straight away they can land up with on that line of surgery. So in such cases, is any other clue? Your is headache is there, inflammation, so ESR and any other blood parameters which may guide us.
So obviously, key first most important thing is what is the way of presentation? How quickly did the patient present with the visual loss? And of course, any associated, so a detailed neurological examination, including cranial nerve examination, is a must, because the rapidity and mentioned about the headaches would give you a suggestion that probably there may be more to it than a pituitary macroadenoma, which may be very silent. The next thing is the visual field. So what is the nature of the visual fields? If it's an inflammatory, it may not so easily just coincide with a compressive lesion where your bitemporal hemianopias may be very straight and clear. But if there is an overlap following on to the nasal field also, then that was more likely seen in inflammatory pathology as compared to pathology. So again, we come back to the same thing that, a detailed clinical examination, knowing the history, and doing an examination would be essential to look for motility defects. So are there subtle motility defects? Although large pituitary and macroadenomas also have been known to be involving the cavernous sinus and then causing nerve palsies, but again, if it's an inflammatory lesion, it's far more likely that the problem, so your lesion may be apparently limited to the pituitary area, but because of the inflammation spreading to the cavernous sinus, you may have motility defect also. So these would be our clinical red flags. The moment there is even one thing that does not fit into the comprehensive picture that we have kind of made for that patient based on the diagnosis, you need to stress. But excellent, I think that was good. It's lucky that we got away with this slight oversight. Of course, I like again stress, it's important to always go back and forth again to the radiologist to make sure that you are resolving all queries that are there before you take a final decision. Thank you very much. I think we'll go on to the next case.
So Dr. Isha Chaturvedi is not here,
She's
right?
here.
No.
No.
So we have Dr. Amruta, and she's going to present on optic neuritis. Is that your case?
Good afternoon all. Thank you for this opportunity. I'm Dr. Amrita from Government Medical College, Kozhikode. Today I'm here to present a case on MOG-positive bilateral optic neuritis. So small background. Optic neuritis is a cardinal manifestation of multiple sclerosis, aquaporin 4 IgG and myelin oligodendrocyte glycoprotein IgG associated disease. However, the prevalence of MOG-IgG seropositivity in isolated optic neuritis is unclear. So a 36-year-old male, a known case of bilateral optic neuritis, anti-MOG positive, presented with complaints of sudden onset blurring of vision both eyes for a duration of 2 days. There was associated pain on eye movements as well. During his first presentation in June 2019, there was sudden onset of blurring of vision of 1 day duration, pain on eye movements, and he had no non-comorbidities. His visual acuity was 6/6 in the right eye and perception of light in the left eye. He had grade 1 RAPD in the left, and central field examination showed a centrocecal scotoma. His fundus examination showed a temporal pallor of left disc. Anterior chamber and vitreous were clear, and there were no signs of any chorioretinitis. MRI brain was taken, and left optic nerve hyperintensity with post-contrast enhancement was seen, suggestive of left optic neuritis. He was treated with IV methylprednisolone pulse therapy followed by oral steroids, and his visual acuity in the left eye drastically improved to 6/9. And in November 2020, he presented with similar complaints in the right eye. MRI was taken, and it showed hyperintense signals of both optic nerves, suggestive of bilateral optic neuritis. Following, IVMP pulse therapy was given, and his vision improved. A neurology consultation was made, and he was evaluated for MOG and NMO antibody, and MOG was found to be positive, and NMO was found to be negative. In April 2021, again, he had an episode of anti-MOG associated encephalomyelitis with bilateral optic neuritis. A neurology opinion was taken, and he was started on rituximab induction following this episode. And throughout the course, he was on oral steroids. After a month of tapering steroids, OCT macula was taken, in which there was serous macular detachment in both eyes, which was probably steroid-induced. And in May 2022, he was presented with blurring of vision in both eyes. His systemic and general examinations were normal, and the vision in his right eye was half-meter counting fingers, and left eye was 6/60. Pupil was bilaterally sluggish, and color vision was defective in both eyes. VP showed prolonged P100 latency and low amplitude in both eyes. This is the OCT picture. In the right eye, there was a large serous macular detachment, and in the left eye, there was pachychoroid and ellipsoid disruption. This is a fundus picture of right eye. The media was clear, disc margins were defined, and there was a temporal pallor, and macular edema was present, vessels were normal. Left eye, media was clear, disc margins were blurred, and there was a temporal pallor, and vessels were normal. A diagnosis was made of MOG-associated optic neuritis recurrent episodes. He was treated with IV methylprednisolone pulse therapy, and he was discharged with tapered dose of oral steroids, and he was also on rituximab. On 2 weeks follow-up, he showed an improvement of 6 by 36 in his right eye and 6 by 12 in his left eye. So its conclusion, a presence of recurrent and often bilateral optic neuritis is an important clinical hallmark of MOG-associated diseases. Early and accurate diagnosis is important for selecting appropriate management, and long-term follow-up is important for MOG optic neuritis patient with prompt and adequate treatment as the key to attain a good outcome. Thank you.
Nice. There are a few comments and a few. One, in the initial episode, you said the patient came on day 1 or whatever, 1 week following an acute attack, and you mentioned temporal pallor, so which something which I would not really expect, because it's an acute. It takes 4 to 6 weeks of inflammation to produce temporal pallor. So that's just a comment. Now, as far as your main disease is concerned, there are two antibodies which are known right now, NMO, that is aquaporin 4, and MOG. And both, they circulate antibody, they attack various parts of optic nerve, and then that's how they cause reduced vision. Now, NMO is much more aggressive, more likely to recur versus MOG. But because now we know that the optic neuritis is because of these circulating antibodies, most of these patients would be, as soon as you know that it's positive, a lot of times even if you don't find antibodies, they would be put on steroid-sparing anti-inflammatory agents for a longer period of time. In NMO, it might be much longer, even for MOG, for a year or two, precisely to prevent these kind of recurrences. So that's something which you should keep in mind, that if you have an evidence that antibodies are circulating, there is in all likelihood a patient may require some steroid-sparing cytotoxic agent.
Yeah, and in the next slide, you talked about the MRI being normal, I think, right? In the first episode. The MRI, okay, it was just an optic nerve involvement. So the other important thing is, of course, to look for and comment on the brain. And remember, the investigation to order when you are suspecting optic neuritis is not just an MRI brain or even with orbits, but with contrast with fat suppression and flare. Okay, this is, and if you can't remember all that much, you can actually write an MS protocol. Now it's actually kind of, clearly defined as an MS protocol in radiological terms and radiological circles. So you need all these components. You need fat suppression for the orbit to look at the optic nerve enhancement. And the other thing, that not only would there be enhancement in MOG, you may have an enhancement that is in the sheath involvement. So these are early signs that can help us before we get our blood test available in the first go itself. Sometimes, as has been done in this case, often we don't do an NMO MOG in the first episode of optic neuritis, especially because of financial reasons and also because of the availability of these blood tests. So you would probably, in your first event itself, just get an MRI done. But just remember, we don't cut corners because we get a lot of information. So the MS protocol, although more expensive, will tell us a suggestion that it may be MOG because of the perineural sheath involvement, or NMO because in the MRI it's involving parts of the brain where the aquaporin 4 is more so in the midbrain region, in the hypothalamus region. So in those areas where you know that there is a higher density, so these may help us to identify. So that is our early signpost, and as Dr. Ashman mentioned, that without waiting for it, 1, we give IV methylprednisolone, and 2, we discuss for a longer duration of steroids in these cases, and also think in terms of steroid sparing. But excellent, I think it's a typical case. It's a case that we all must be aware of, and something that we are increasingly seeing. So before this, we were not really understanding that, why optic neuritis that we see is different from what ONTT actually described, and now we are learning that there's so much different, and it's important for us to know because these are far more common in the Indian or in the Asian population as compared to the Western. So although still optic neuritis because of multiple sclerosis or idiopathic will be the more common one, but percentage wise we'll see a lot more NM or MOG in Asian population as compared to.
And just the last point, that all these, especially MOG patients, you should ask history of COVID or COVID vaccination, Covishield. Because there is a perception that COVID-19 infection, prior infection within a few months, if they come with optic neuritis, there is a possibility that it could have triggered one of these antibodies.
Just one simple point. If that some are not in a very city major cities, radiologists are not too much tuned. In such cases, instead of writing orbit MRI brain death, my protocol is that I just advise visual pathway. It will be little easier because technicians are doing basically the MRI. So straightway in COVID scenario, as Dr. Rasmin rightly mentioned, so straightway we can write in a one set a visual pathway with phase suppression with contrast. It will cover all.
Thank you. You can call the next.
Dr. As per our that is another it will kill time, and we don't know the radiologist how much tune with that system. Neurologist, you can, but you straightway you can advise for all. Then you can
So you
diagnose
start
yourself.
your interventions because
Then-
it is more important to start methylprednisolone unless you have a doubt to the diagnosis. So at the moment the patient presents, you get an imaging done and you start IV methylprednisolone. We don't do too many, there are not too many other tests that are required. A baseline blood test is what we do, a basic electrolytes, just so that we don't have because of the complications of steroid and a chest x-ray. But other than that, you can start IV methylprednisolone, get an imaging done, confirm and identify. If there are suggestions of NMO-MOG, must get a neurologist opinion. Even if the MRI is showing signs of multiple sclerosis, you must get a neurologist opinion, because then these diseases are no more related or limited to the eye. Now they are neurological diseases with ocular presentation. So the patient in the long term will have to be managed by a neurologist. As if it is absolutely normal and you think it is idiopathic optic neuritis, you may do the treatment, manage, but advise the patient that the patient should get evaluated by a neurologist, because we may miss signs of a previous neurological event, which will again show that this is a patient of multiple sclerosis presenting with optic neuritis today. So a neurological assessment in the long term in all these patients of neuritis, because finally it's a neurological disorder with an ocular presentation.
But yeah, Dr. Jubin, please.
Dr. Jubin will be presenting on.
He will be presenting in that a case of bilateral optic neuritis post-COVID, very important.
So we are now what Dr. Rashman actually mentioned about. Yes, Dr. Jubin. Timer लगाना है यार. Dr. Jolly Rothke की presentation. और timer लगाना है. हम भी ऐसे ही बोले चले जा रहे हैं, हमें पता नहीं.
Good afternoon everyone, I am Dr. Jubin, PG resident, Department of Ophthalmology, UCMS. I am going to present a case on bilateral optic neuritis post-COVID-19 vaccination. A 15-year-old female presented to eye emergency with 2 days history of acute loss of vision in both eyes. There is no history of ocular trauma, systemic illness, no history of COVID-19. There is history of COVID-19 vaccination 2 days prior to the onset of symptoms. General and systemic examination within normal limits. On ocular examination, vision in the right eye is PL positive, PR accurate. Left eye, hand movement close to the face, PR accurate. Color vision, both eyes appreciate shades of grey and black. On Hirschberg test, approximately 10 degrees left divergent squint. Pupil, both eyes round and regular, mid-dilated and sluggishly reacting. Fundus examination shows in right eye nasal blurring of the optic dispersion and left eye myelinated nerve fiber around the disc. Rest ocular examination within normal limits. Routine investigation within normal limits. Inflammatory markers within normal limits. Torch, HIV, hepatitis B, C, VDRL, they are non-reactive. Chest X-ray within normal limits. CECT brain with orbit done, which shows ill-defined hypodensities in bilateral capsula externa. Optic nerves appear normal. Pediatric and neurology consultation was done, and pediatric consultation within normal limits, and neurology consultation they advised to start IV steroids. CE MRI brain with orbit done, which shows gliosis in bilateral capsuloganglionic region with enhanced nodule along it. Optic nerves appears absolutely normal, and CMRI spine is also done, which is also within normal limits. So our provisional diagnosis is bilateral optic neuritis post COVID-19 vaccination, and possible differential diagnosis were neuromyelitis optica optic neuritis or multiple sclerosis associated optic neuritis. In treatment, we started injection methyl prednisolone 1 gram IV OD for 3 days, followed by oral prednisolone 40 mg with tapering dose for 11 days. So course of the disease. So there is an improvement of the vision with decreased disc edema noticed 4 to 5 days after the starting of the steroids. So after 4 to 5 days, vision in the right eye is finger counting 3 meter, PR accurate, left eye finger counting at 1 meter, and PR accurate. Pupil brisk reaction in both eyes. However, patient started developing slurring of speech and altered behavior 10 days following initiation of the steroids. So the repeated neurology reference was done, and they advised anti-MOG and NMO antibody test and CSF examination were advised. Systemic steroids again increased to 40 mg daily. However, patient deteriorated further and was transferred to neurology for further investigation and management in IBAS hospital. So under them, CSF study was done, which is within normal limits, and NMO antibody test within normal limits, and patient refused for the MOG antibody test. And a further course of IV methylprednisolone was given for 3 weeks by a neurologist, and followed by oral steroid, which were tapered very gradually. So after 6 months follow-up, vision in the right eye improved to 6/24, in left eye improved to finger counting at 3 meter, and PR was accurate. Color vision normal in both eyes, pupil reaction normal in both eyes, and in fundus shows there is a resolved disc edema in the right eye with disc pallor, and in left eye there is myelinated nerve fiber around the disc. At 9 months follow-up, vision in right eye improved to 6/12, and left eye 6/24, rest same. So the COVID-19 vaccination, like any other, can cause side effects, mostly low-grade fever or muscle aches, and rarely neurological ones. According to vaccine adverse event reporting system, since the vaccination was developed, there has been 58 cases of optic neuritis reported worldwide between January 1 and June 30, 2021. 3 cases reported in India, all were adult and unilateral. Post-vaccine optic neuritis is a known but uncommon side effect where the exact mechanism remain unknown. Mostly believe that the vaccine activates the host immune system, leading to T cell activation, which damages the myelin sheath of the optic nerve. In the present case, the COVID-19 vaccination presumably triggered an autoimmune response and bilateral optic neuritis, which it is difficult to prove the association with the causation of the vaccines. And conclusion, ocular side effect of COVID-19 vaccination till date are ill-defined and poorly understood. Our case is rare, in which both CNS and optic nerve is involved, which responded to long-term steroid therapy. Thank you.
Yes, nice. So that's what we discussed just before this, that these vaccinations, though, I mean, I've not heard so much with Covaxin, it is probably a little more common, and these are just observation, we don't know really, we don't have enough data, that it is probably a little more common with Covishield or with infection itself, and it can trigger variety of these optic nerve related problem or CNS related problem, and we should be on the lookout.
The mechanism behind it, did you look up or anything? Why the vaccination should result in a lesion, a problem like this?
Sir, because it activates a host immune response, sir, like cross antigens, sir.
Right, absolutely. So exactly what, so all vaccinations have inherent among them an attempt to stimulate the body's response to an antigen. While the aim is to give this as an adjuvant because you are giving an antigen to which you want the antibody response, but that stimulation can be across the board. So this is a possibility that is being suggested, that these patients may be susceptible to getting this disease, however do not get it and may not ever get it in their lifetime because the amount of antibody circulation is very less and there is nothing to trigger. But this stimulation, general broad stimulation of this, may give rise to a potential likelihood. So that is, I mean, besides of course the other mechanisms by which COVID can act, the vaccination is the increased likelihood or the reports could be possibly because of this. But again, these are areas which are grey and we're not so sure. So, any comments? And then
of course, it's very difficult, though we assuming only there is a, Dr. Gandhi, is there anything, can we prove it by any method, anything?
confirm that it is post-vaccination.
Very difficult. I mean, both COVID and vaccination, there is, it is only the temporal relationship that there is an infection within few weeks, or you gave a vaccination within a few days. the event started, and because it is known, it is known that it can happen, but there is no way to say that cause and effect at the moment.
Yes. Or it may be due to the with COVID itself. Subclinical COVID earlier, maybe in unknown patient, maybe one of them.
Thank you. Thank you, Dr. Zubin, for a very interesting case and a very important one. And till the time we confirm that it is post-vaccination, we should still leave it ambiguous, because we do not want to get the vaccination system into a bad name. Yes, so there is something, still, COVID is definitely worse than the vaccination, that we are still sure of. Is there Dr. Mahfouz Alam? So I think we will now have the bright spot, Dr. Prasanna Venkatesh, to speak on diagnosing early glaucomatous damage in a homonymous hemionopic patient with spectral SD-OCT.
Yes, thank you for the opportunity. So this is a case on diagnosing an early glaucomatous damage in a homonymous hemionopic patient. So in clinical practice, the differentiation of glaucoma from a non-glaucomatous neurological damage can be really difficult for even experienced observers. But to add on, what if there is a coexisting glaucomatous cupping and a non-glaucomatous neurological damage together? It makes things extremely difficult even for experienced people as well as for neophytes. So in this case, an early glaucomatous damage in a disc which had a pre-existing non-glaucomatous neurological damage is being discussed. It's a holistic evaluation along with the new Brooks membrane opening minimum rim width tool, which is currently revolutionizing the glaucoma practice. Previously, Brooks membrane opening horizontal rim width was the one that was being used, but now the novel minimum rim width is come into play, and let us see how. So the green is the internal limiting membrane and the red line is the Brooks membrane. And currently the OCT parameter is changed, and it's an evolution in glaucoma practice where the minimal distance between the ILM and the Brooks membrane is the one that glaucomatologists are recommending, and studies have also thrown light on it. So this is a normal disc where you can see that previously the traditional horizontal rim width was the one with the orange arrow on the left hand side bottom, which was the one that was taken, but now it's the blue Brooks membrane minimum rim width, which even detects a pre-perimetric glaucomatous damage. The main advantage of this technology is the GPS system, or the anatomical positioning system, as it is told, where the fovea center is first marked and then the Brooks membrane opening, that is in terms of disc area, that centration is marked. The fovea BMO axis gives us a plot, so a small head tilt or even a patient who comes in follow-up, the same piece of tissue is examined at every visit, so it moves towards more better reproducibility. So this patient, a 73-year-old male patient who had a left occipital lobe infarct 30 years back, had a right homonymous hemianopia with macular sparing. He is complaining of a mild diminution of vision in the remaining field of vision, the remaining seeing area in the last 1 year. So the routine annual checkup, he also had a family history of glaucoma too, and the visual acuity is 6/9 and the color vision is normal, anterior segments are perfectly fine. And the diurnal variation is also very tricky here because when we did a phasing, the peak was 21 only. It did not cross the 21 barrier, but still we had to think in terms of normal tensive glaucoma. Both the eyes, there was a fluctuation with 12 o'clock and 10 a.m. in the right eye and left eye respectively, 21 being documented, and that is the right skewing deviation in the Gaussian distribution curve. And the posterior segment examination, there was a mild temporal pallor owing to his neurological issues, and the cup disc ratio was 0.7 and 0.8 respectively, and this is the fundus photograph of that particular patient. And 24-2 and 10-2 was actually done, and this is the visual field of that particular patient, 24-2, and this is a 10-2 of the same, depicting some more localized defect in the other area as well. And this is the Brooks membrane opening minimum rim width of OD and OS. You get up to 48 segmented scans respectively. And this is again the deep cupping seen in the right eye and the left eye respectively. So you can see here the RNFL as well as the ganglion cell layer, when the progression analysis was plotted, there seems to be between the December 2019 and March 2020, a span of 4 months, there seems to be a slight loss of RNFL and ganglion cell layer even in the seeing area corresponding to that particular structure, both in the OD as well as in the OS. So that was one particular catch in this patient. So the rationale of diagnosis was one, the history taking, that the patient himself telling the last 1 year he has mild diminution of vision, and occipital lobe infarcts does not need to cause a non-glaucomatous cupping, that's point 2. There was a diurnal variation of IOP, not enough for a POAG diagnosis, but at least NTG was contemplated in this particular patient. The basic signs of ISNT rule being breached in this particular patient, and also the OCT documentation with inception of superior arcuate scotoma even in the other seeing area. It has crossed the midline. And this particular technology, it's one of the first cases to apply this, and it is due for publication, not yet published, with the APS Brooks membrane opening minimum rim width for early diagnosis of glaucomatous damage, even in a neurological case or a non-glaucomatous neurologically damaged disc. Thank you for this opportunity. These are my references.
Very, very nice thought, though. I mean, of course, I have never deployed it in my practice. I'm not. There seem to be a lot of discussion in glaucoma circles as to how much would you base your decision only. I mean, mainly on OCT, right?
Yes,
I mean, if you have changes in the OCT, would you go ahead and treat, or would you go ahead and act? And that's partly what
Yes,
it
sir.
seems like, because you had the variation did not really say. I would also look at the visual fields and say that the eye which had a predominant temporal defect, if they start developing nasal defect, you know that probably there is an overlay
You
of
could see that, and if that's
Yes,
progressive,
overlay
then
of glaucoma on the previous neurological problem.
So it was a more holistic, not only the OCT.
know.
Yeah, yes, sir. Yes, sir.
I guess, I mean, as we are seeing with time, technology is evolving in our understanding of information from there. The only, of course, the important thing to remember whenever we're dealing with technology is the minimum change before which you consider it significant.
Yes,
So consistency of the change and the minimum variation before which we can take it. But I guess we are still searching for, because unfortunately there are many cases that get misdiagnosed that are pituitary tumors, and because of the excavation of the disc that follows a compressive lesion, they are misdiagnosed and managed as glaucoma, and the vice versa, pituitary adenomas which may be secreting, may result in an increased steroid milieu in the body, resulting in glaucoma. So there are patients who've been managed as glaucoma because they do have moderately increased pressures but are progressing, and they actually turn out to be macroadenomas. So it's very, very important for us to, as technology helps us to be able to, add to clinical armamentarium to differentiate between and see where both are there. So very nice. It's a very good thought, and we hope that more and more objective criteria come in so that we are able to, with more confidence,
Yes,
give this, get this idea in place.
Very good initiative.
Thank you, sir.
One point, and just one very difficult. So can you highlight that, of course, there is some openings, sensing in the, is there any some pattern in glaucomatous or any neuro-ophthalmical? Is there any sense, any difference in between neuro-ophthalmical cause or true glaucomatous cause?
So that is the confusion, sir, because there is not a fine line between that and this. And moreover, to add on to this case, even the IOP did not cross 21 also. So that was even more trickier, and
Not in this case.
yes, sir.
Anyway, any suppose.
Maybe not, according to my knowledge, not till now, but maybe maybe it may happen, sir, in the
Yes,
future.
definitely.
Maybe,
we
sir.
can think for.
Unfortunately, life is not in black and white and
Yes, sir, it's
sharp
grey.
corners and sharp edges. So thank you.
Thank you, sir. Thank you for the opportunity.
We'll go on to the next presentation. Dr. Alma Varghese. She'll be presenting a case of MOG optic neuritis. So just on the sheer numbers, we know that MOG and NMO are now becoming more and more of clinical importance for us. Dr. Nishi is there, Dr. Nishi Prasad. So we'll thank her for helping us to complete this session on time.
Good afternoon, everyone. My name is Dr. Elma Varghese. I'm a junior resident in GMC Kozhikode. Today I'm going to present a case of myelin oligodendrocyte glycoprotein optic neuritis. So a 23-year-old male presented in our casualty with sudden onset defective vision in left eye for 2 days. He also had associated pain on left eye movements. He had history of similar illness in the right eye. First episode in 2012 and second episode in 2017, for which he was treated with IV methylprednisolone followed by oral prednisolone, and his vision improved. There's no history of any associated comorbidities. On examination, his general examination and systemic examination were within normal limits. Ocular examination, right eye anterior segment were within normal limits, except pupil direct reflex was brisk and consensual was sluggish. Best corrected visual acuity of right eye was 6/6. Left eye showed grade 3 RAPD with best corrected visual acuity of perception of light with PR accurate. This is a fundus picture of the right eye, which shows the media was clear, the dismargins were defined, the cup disc ratio of 0.3, and there was a temporal pallor. The vessels and peripapillary area were normal. This is a fundus picture of the left eye, showing again media was clear, the dismargins were defined, temporal pallor were there, vessels and peripapillary area was normal. So after obtaining this history and a clinical examination, we came to a provisional diagnosis of retrobulbar neuritis left eye and recurrent optic neuritis right eye. We kept the differential diagnosis as multiple sclerosis, NMO spectrum disorders, and MOG-associated disorder. Investigations. Routine investigations were within normal limits. MRI brain was done, which came out to be normal. There were no evidence of optic nerve enhancement. VEP showed reduced amplitude in both eyes. Serum MOG and NMO was done, out of which MOG IgG came out to be positive. This is a OCT imaging of the right eye showing thinning in the temporal neuroretinal rim. This is a OCT of the left eye showing thinning in the temporal neuroretinal rim. So after that, we came to a final diagnosis of MOG-positive optic neuritis. Patient was given intravenous methyl prednisolone therapy, 500 milligrams BD for 3 days, which was followed by tapering doses of prednisolone. Neurology consultation was sent in view of serum MOG positivity, and patient was given 2 doses of rituximab injection and is now regular follow-up now. Vision in left eye showed significant improvement to 5-meter counting fingers from perception of light. Discussion. The phenotype of MOG-associated disorder is broad. It includes optic neuritis, transverse myelitis, acute demyelinating encephalomyelitis, brainstem encephalitis. Optic neuritis is the most common presentation in adults, whereas ADEM is the most common presentation in children. Clinical characteristics suggestive of MOG-IgG optic neuritis include recurrent optic neuritis, prominent disc edema, perineural enhancement of the optic nerve on MRI. Initial presentation of the patients with NMO and MOG is similar. Diagnostic evaluation in patients with acute optic neuritis should include assays for both NMO and MOG IgG antibodies. MOG optic neuritis respond well to steroid, unlike NMO SD optic neuritis. Some develop a condition called chronic relapsing inflammatory optic neuritis, characterized by recurrent episodes of steroid-sensitive optic neuritis. Therefore, in patients with presumed chronic relapsing inflammatory optic neuritis, an assay for MOG antibody should be performed if not done already. Role of immunosuppression in MOG optic neuritis. Sometimes it can present as a monophasic illness. In such cases, chronic immunosuppression may not be required. If disease recurs or present with other neurological manifestation, acute treatment with steroid and chronic immunosuppression should be considered. Thank you.
Very nice. Since we had quite a bit of discussion on MOG and optic neuritis, so you actually nicely summarized and you summed up everything which happened in the previous 3 cases. Thank you. Thank you so much. Lovely. And may I have Dr. Rana Jamil for secondary optic atrophy?
Good afternoon, everyone. I am Dr. Rana Jamil, Fellow Comprehensive Services from Center for...
Bring the mic down a little bit. Yeah.
I'm going to present a case of secondary optic atrophy, a rare presentation of Takayasu arteritis. A 32-year-old female referred from retina clinic with painless loss of vision neuritis since 4 months. It was associated with dizziness. She was non-smoker, non-alcoholic. There was no history of snoring, fever. She was non-diabetic, non-hypertensive, no migraine history, no relevant surgical history. There was no history of trauma. But she had a history of first episode of numbness and tingling sensation of the left upper side of the limb 4 months back, followed by right side upper limb and dizziness. Followed which she had an acute onset of diminution of vision of the right side, which was painless and progressed to present stage within a month. She consulted an ophthalmologist that time, and from her records, we could find that the vision was 6/12 part in right eye and 6/12 in left eye. She was prescribed glass and multivitamins. She also consulted physician, and on noting a feeble pulse and low BP, she was advised a number of tests, and the tests most of the tests were within normal limits, except hemoglobin was 9.2 and ESR was 29. ECG was normal except for short PR interval. MRI was unremarkable. MRI brain was unremarkable. She was given treatment for anemia and referred to cardiologist for further investigation and treatment management. Cardiologist advised him 2D echo, color Doppler of both upper limb, but the patient did not go for the tests. And after 2 months, she came to us and in retina clinic, and from where she was referred for neuro-ophthalmic opinion. On general examination, she was of average build. Her radial pulse was feeble. It was 56 and beats per minute, and BP was 71/48 in the left right upper limb, and both in the left upper limb BP was also low, 70/47, and pulse was 55. We took the blood pressure and pulses of both the lower limbs, and it was in normal range. On ocular examination, BCVA in the right eye was finger counting close to face and N24, and in the left eye it was 6/6 part and 6. IOP was 7 in right and 9 in left eye. Colored vision in the right eye could not be performed, and in the left eye it was normal. The rest of the anterior segment examination was unremarkable except RAPD in the right eye. Fundus photograph of right eye shows blurring of the disc margin, and the CD ratio was approximately 0.5. There was mild disc pallor and tortuosity of vessels, and the FR was dull. In the left eye, there was mild hyperemia in the upper part of the disc, small disc with CD ratio of approximately 0.2, and suspected to be disc at risk, and there was tortuosity of vessels, and FR was dull. HBFA 24-2 of the left eye was within normal limits, and right eye could not be performed because of its low vision. OCT of the right eye shows GCC loss. OCT macula, both eye, normal foveal contour. Her ESR was 29 millimeter per star, CRP was 24.3. FFA was advised to rule out any retinopathy, but the patient refused to do it. Based on the favoring points like elevated CRP, ESR, and vasculopathic factor suspected of Takayasu arteritis, the age was less than 40, and crowded optic disc fellow eye, and after ruling out the optic neuritis comprehensive and hereditary optic neuropathy, we came to a provisional diagnosis of right optic atrophy post-anterior ischemic optic neuropathy with anemia, and the diagnosis was suspected to be Takayasu arteritis. We referred to cardiologist for confirmation of the diagnosis. CT iotogram was performed, and it shows near total occlusion of the subclavian arteries. Bilateral CCA shows 80 to 90% luminous stenosis. Right internal carotid artery was approximately 90% occluded, but the left internal carotid artery was mildly, there was mild luminal narrowing. Both the vertebral artery were significantly involved. Based on this finding, diagnosis of Takayasu arteritis was confirmed, and we started with, in collaboration with the cardiologist, she was started with prednisolone 40 milligram OD and tablet mycophenolate mofetil 500 milligram BD. And the plan of treatment was to taper the prednisolone once ESR and CRP comes to normal, and to increase the dose of mycophenolate. Patient was advised to follow up after 2 weeks, but unfortunately the patient lost to follow up. On telephonic conversation with the patient after 2 months, we tried to contact her, and she said she is symptomatically better, but refused to follow up. So Takayasu arteritis, as we all know, is an inflammatory vascular disease which has predilection for aorta and its branches, more common in young females of Asian or Hispanic origin, and occurs in younger patients, mostly in the second or third decade. It can manifest with the ocular manifestations can be because of hypoperfusive occlusive arteritis of aortic arch branches, or because of hypertensive because of involvement of retinal artery or renal artery or suprarenal aorta, and it can be treatment related complications. Anemia is a common associated condition, and the take-home message I want to emphasize is we must check radial pulse and BP, and we should be familiar with the ocular manifestation of Takayasu arteritis. We should consider Takayasu arteritis as a DD in patient with atypical presentation in AION, so that the early diagnosis and referral can be sight and life-saving as well, and multidisciplinary collaboration mandatory to achieve the best therapeutic approach. That's it. Thank you.
Thank you, of course, and in regards to Professor Pradeep Sharma, my teacher also. So lovely to see a case coming from there. It's very, very important as a differential in a young patient presenting with what you suspect as ischemic optic neuropathy, because that is a major differential for that. And it's good that you picked up early, and of course, it has to be managed in conjunction with a cardiologist. Not too many cases come, thankfully. Unfortunately, there's not much you can do for the affected eye, but yeah, it's very, very important that interventions are early, because it's very important for the life, long-term life expectancy of a patient.
Very good. Your way of presentation and then your investigation, everything fine. But I just had one point. In such scenario, instead of a simple OCT, you can go for a NG-OCT. NG-OCT will give more information. It will be helpful for cardiologist, because in center for side, I think NG-OCT is available.
So it was advised by retina people. And
No, that's no. If someone advised, no, we are presenting case, that's the reason we should know, as we are all ophthalmologists. So NG-OCT in center for that is available. So straight away you can go for NG-OCT. And for any optic nerve disease, for the youngster I am telling, do not say only OCT. It is OCT RNFL, because technician will know that term only. RNFL, OCT RNFL means he will look around the disc. Otherwise, he will do the macula, because retina people are doing maximum 95%
with the
macula. Macula OCT will be useless. So always mention RNFL. The term is RNFL. If NG-OCT is there, with our neuropathy machine is available, so RNFL, NG-OCT.
Thank you. I'll just ask Dr. Ashwin for comments on this case and the concluding remarks.
Yeah, very, very nice. And as I think, again, the conclusion in all the cases are that optic nerve is part of brain, and it also gets affected with all these fluctuation in the blood pressure, diabetes and whatnot. So we have to be alert about all these systemic conditions. And it was a very nice bouquet of very interesting cases, and all of you presented very well. And we hope that we had some take-home message for each case. Thank you. Thank you very much.
All speakers can come up. We can have a photograph. And thank you, everybody. We hope to hand over the hall on time.